I'm Dr. Michael Sims, Chief Infectious at St. Mary's Hospital in Waterbury, Connecticut. And lecture this morning, I'd like to cover tick-borne diseases that I've cleverly titled Approach to Patients Who Are Ticked. I'm not going to be spending a lot of time talking about the specific pathogens or about the specific diseases. Instead, I'd like to address a need that's come up with many clinicians who have asked for a logical approach to a patient who believes they may have been bitten by a tick, and a logical approach to treating those illnesses that are spread by ticks we call tick-borne diseases. Connecticut, by the way, has every tick-borne illness in North America except relapsing fever, which is only found in the Rocky Mountains. So it's very important for physicians in Connecticut to be aware of a proper approach to tick-borne illnesses, because we'll see them as we care for our patients, particularly as you'll see during the warmer times of the year when tick bites are much more prevalent. Now, the first thing to ascertain when the patient comes to you and reports they've been, quote, bitten by something and believes they may have been bitten by a tick is to assess whether, in fact, it was likely a tick bite. There are several ways to tell. You see on the slide on the left-hand side, it's less likely to be a tick if it's pyretic. Ticks have an antipyretic as well as an analgesic in their saliva. Remember, they have to feed for 3 days and not be discovered or removed by the host animal. So often the patients will not complain of pruritus at the site of the bite, where with an insect bite, with the insect saliva, the often is pyretic. Secondly, often insects and other biting arthropods will often bite on the distal extremity. Mites, for instance, mosquitoes, bed bugs. Ticks, however, because they like to find intertriginous areas of the body where they will not be discovered for the 3 days they need to feed, will often bite on the proximal extremity. So if the bite is painless and on the proximal part of the extremities, particularly intertriginous areas, axilla, inguinal area, gluteal folds, under layers of fat, that would increase the likelihood it may have been a tick bite. If the patient brings the arthropod that bit them with them to your office or the emergency room or clinic, it's a good idea to look at it either under a microscope, or if you don't have a microscope available, use your ophthalmoscope and you can focus on the tick and count the number of legs. Ticks are arachnids, so they're going to have 8 legs, 4 pair of legs, just like a mite or a spider, a scorpion, a tick, a lobster, which I don't think we'll see too many of, lobster bites. However, if you see 3 pair of legs, 6 legs, no matter whether it's non-pyretic and on the proximal extremities, more consistent with a tick, it's an insect, and it's not going to be a tick. You can reassure the patient they have no risk of a tick-borne illness. They were bitten by an insect and not a tick. Remember that the tick-borne illnesses, because they're spread by ticks, are going to occur during those seasons when ticks are active. In the case of the tick that spreads Lyme disease, anaplasmosis, ehrlichiosis, Borrelia miyamotoi, and babesiosis, that's the nymph stage, and they predominantly will feed in the warmer times of the year, May to October. If it's in the colder parts of the year, November to April, it's less likely to be a tick. However, remember that adult female Ixodes ticks will feed during warmer times in the winter, and there have been tick bites from adult female Ixodes ticks during warm spells in January and February. But for the most part, we're going to see tick-borne illnesses during May to October. Again, in assessing the patient as the risk of a tick bite, look at the epidemiology, strictly the time of the year, as we covered in the last slide, during the warmer times of the month. Does your patient have any known woods or brush exposures? Remember, the ticks will live in long vegetation in cooler areas where they don't become desiccated. So has your patient, in fact, been exposed to that type of environment where they could have encountered a tick? Even if they don't enter those areas, do they have pets, particularly dogs or cats, that enter the woods? And then does that pet sleep with them in bed or jump up and sit on them with the couch or the chair, which would increase their risk of being bitten by a tick? If they don't have exposure to woods or brush or long grass, if they don't have pets that could bring them in, that would very much diminished the risk they may have been bitten by a tick. And then, have they ever found ticks on themselves? When they've been outside gardening or working in the woods or on the lawn, have they in fact found ticks on themselves when they've come inside? Now, if you assess that it is likely a tick bite, then you want to assess whether they're having any symptoms of a tick-borne disease. And like all patients, we want to take a careful history, do a physical, and then work them up appropriately to determine, do they have a tick-borne illness or do they have another illness? Remember that the symptoms of tick-borne illnesses can look very much like other illnesses that you would see. So it's important to differentiate. If, however, the patient reports to you they were bitten by a tick, and as far as you could determine they were in fact bitten by a tick, and it's an Ixodes tick, a small, soft tick, not the larger, hard ticks, then the next question is, well, if they don't have symptoms, I don't need to treat them for an illness, but do I need to prophylax them? There is one study that was done out of New York Medical College, Wormser et al., that looked at decreasing the risk of Lyme disease specifically after a tick bite, and found that if patients met 4 criteria, they would be candidates for doxycycline prophylaxis following a tick bite when an Ixodes tick. First of all, they have to come from an endemic area. Second of all, was the tick attached for more than 36 hours? Remember, it takes greater than 36 hours for a tick to transmit Lyme disease. So if the person ascertains that they found the tick, even if it's embedded and somewhat engorged, but they can ascertain it was definitely less than 36 hours, that very much diminishes their risk of Lyme disease. Has the tick been removed in the last 72 hours? Have they come to see you within 72 hours of removing the tick? If they come 2 weeks later to report this happened, they're out of the window for prophylaxis. And lastly, the study was only done using doxycycline, not other antibiotics, so there can be no contraindication to doxycycline. No allergy to doxycycline or tetracycline. They have to be above 12 years of age, and they can't be pregnant. If they meet all 4 of those criteria, they would be a candidate for a single 200 milligram dose of doxycycline once. You don't need to treat them as if they have Lyme disease. One trick I've learned, 200 milligrams of doxycycline is pretty rough on your stomach. I advise patients to take it with a large glass of water and 20 minutes later take another large glass of water in order to minimize the risk of nausea or vomiting taking 200 milligrams of doxycycline. Now, if the patient does have symptoms and worried about a tick-borne illness, you want to take a history looking for specific symptoms that would suggest a tick-borne illness. One thing that most of the tick-borne illnesses have in common is they all give the patient a terrible headache. So does the patient have a headache, even one that might be consistent with aseptic meningitis? Do they have body aches? Do they have arthralgias? Remember, early on in Lyme disease, the patients don't have arthritis, but they will have arthralgias. Do they have facial weakness that you might note in the next line? Your physical is consistent with facial paralysis. And do they have a rash, or have they had one previously that is consistent with erythema chronica migrans? Now, one trick I've learned is using smartphones. Often patients will come reporting they had a rash, but it's gone. And the resolution of smartphones is such that I've been able to ascertain that the patient did in fact have erythema chronica migrans, even if it was in the weeks preceding the visit. So examine the patient for the rash, concentrating particularly on the proximal parts of the extremities, the intertriginous areas, looking for evidence of erythema migrans. Ask if they have a picture on their phone of the rash if it occurred previously and has since resolved. Remember that finding erythema chronica migrans is important. It's the only specific aspect of history of physical to Lyme disease that occurs with virtually no other disease. So if you can ascertain the presence of erythema chronica migrans, that lends a lot of certainty to diagnosis of primary Lyme disease. Next, the physical examination. Do they have meningismus? Again, tick-borne illnesses, Lyme disease, Atoplasma, Ehrlichia, Borrelia myomodi, have all been associated with aseptic meningitis. And it's also important, we'll touch on it later in the treatment, to ascertain if the patient has aseptic meningitis in the setting of Lyme disease. So do they have meningismus? Do they have knee arthritis that one would see with a later stage of Lyme disease? Do they have a seventh cranial nerve palsy? Is there an unexplained bradycardia that could be consistent with an AV block that we would see with cardiac Lyme disease? And then, again, looking carefully for the erythema chronica migrans. Now, patients bitten by a tick, or for that matter, bitten by insects, will often have a rash. It's important to differentiate that rash from erythema chronica migrans. And how do we tell the difference? Generally, if it's not erythema chronica migrans, if you look on the left-hand side of the slide, the rash is generally less than 5 centimeters. Erythema chronica migrans is often 5 centimeters and will increase over time, where the reaction to the bite itself will decrease over time. Again, commonly it will be pruritic if it's not erythema chronica migrans, if it's caused by an insect bite, for instance, where erythema chronica migrans, they may complain of burning or pain. The area of erythema chronic migrans is warm because this is actually a cellulitis following the bite of the tick due to Borrelia burgdorferi. So it's a localized circular cellulitis where the bite of an uninfected tick bite or an insect bite will remain cool but pruritic. There'll often be a tenderness associated with erythema chronic migrans because it's an infection. There may or may not be a small amount of ecchymoses, and there will not be any systemic symptoms or signs with a early tick bite where there is no erythema chronica migrans or early Lyme disease, where there will be associated symptoms with erythema chronica migrans if the patient has early Lyme disease. And remember, symptoms on the previous slide, we would be looking for headache, body aches, arthralgias, facial weakness, and again, looking for the rash. Now, if you're convinced the patient might have a tick-borne illnesses and there's no erythema chronica migrans, then you need to look for tick-borne illnesses, including Lyme disease. But if there is erythema chronica migrans and you have a good history of a tick bite and symptoms consistent with it and other physical findings, then you don't need to test for Lyme disease. And there's 2 reasons for that. One, you already have the diagnosis if they've been bitten by an Ixodes tick and they have erythema chronica migrans. And secondly, the serologies will take a couple of weeks to become positive, where the patient will become ill within several days to a week. So often the testing is falsely negative anyway. So it should not dissuade you from a clinical diagnosis of Lyme disease if you've made it based on the good history of a tick bite and the presence of erythema chronica migrans. However, remember that you don't have to check for Anaplasma ehrlichia and Borrelia because you're going to be treating the person with doxycycline anyway. But you do need to treat or test for babesiosis. Babesiosis is not treated with doxycycline. So you need to look for the presence of babesiosis. Even if you've made a definitive diagnosis of Lyme disease, you're going to treat them with doxycycline. That will cover Anaplasma ehrlichia and Borrelia anyway. But remember, you need to look for Babesia. That will not be covered. Do not order an antibody for Babesia. Order the PCR. The PCR test will tell you if the patient is infected now with babesiosis, not a reflex antibody that would appear later. Assess the patient for meningismus and do a lumbar puncture if there's any possibility of aseptic meningitis, because even early stages of Lyme disease require intravenous therapy if there's meningitis in the presence of early Lyme disease. If you're worried about Anaplasma ehrlichia Borrelia, do a CBC and a diff, looking for leukopenia and thrombocytopenia that one would see with those illnesses, and an anemia plus minus decreased platelets that you would see with babesiosis. A good way to look for babesiosis, a sensitive way to look for any hemolytic disease, is check an LDH. LDH will always be elevated in the case of hemolysis. So if you see an elevated LDH in the presence of anemia in the history of a tick bite, it increases the risk that the person might have babesiosis. Now, caution is if you do have a patient with an increased LDH and thrombocytopenia and fever, it may well be babesiosis, but don't forget to think about the differential diagnosis that includes TTP, and HUS. They're far more dangerous illnesses that are also associated with anemia, an elevated LDH, thrombocytopenia, and fever. So if you're worried about babesiosis on the basis of that, make sure you also rule out TTP and HUS, even if it's in the summer and there's an increased risk of babesiosis. Lyme serologies are really only helpful if the patient is in the later stages of Lyme disease, sicker for more than 2 months. Remember, you'd need a positive screen as well as a positive IgG Western blot. The IgM is often falsely positive, particularly if done in the setting of a low pretest probability based on epidemiology, history, and physical. If you've determined that you believe the patient has Lyme disease, then you're going to want to treat. If it's early Lyme disease, you want to treat with doxycycline for 2 weeks. Some clinicians prefer to treat for 3 weeks, but a minimum of 2 weeks. If they have Anaplasma, Ehrlichia, or Borrelia in the absence of Lyme disease, it's doxycycline for 10 days. Remember, babesia is not covered, so if you do diagnose babesiosis, you need to treat them with azithromycin and atovaquone for 7 up to 10 days. If they have severe babesiosis, this would be characterized by a parasitemia greater than 10%, an age over 70, or the presence of asplemia, it would be wise to get an infectious disease consultation. These would be considered severely ill patients, and they could die. We have had patients die of babesiosis, and they will require treatment with clindamycin and quinine rather than azithromycin and atovaquone. Now, if you believe the patient has advanced Lyme disease involving the heart, the joints, the central nervous system, again, refer to infectious diseases because those patients need to be assessed by infectious diseases and will likely need to be treated with ceftriaxone for 28 days. Epilogue. Remember, don't do follow-up testing for cure of Lyme disease. The serologies remain positive long after the patient's been cured. Don't do serial Lyme testing looking for a decrease in the number of bands as a proof of cure. Remember to tell a patient to avoid further tick bites. Remember, if they present to you with a tick bite, that means they're at increased risk for tick bites in the future. None of these illnesses are associated with protective antibodies. So if one lives in a certain neighborhood, has certain recreational and avocational habits, works in the woods, so they work for the utility or they work in landscaping, remind them that now you've cured them of one tick-borne illness or several, but they're at risk again of further tick bites. So counsel them as far as preventing further tick bites. Remind the patient, particularly with late-stage Lyme disease, it will take months for the symptoms to disappear. They need to be patient while the synovial tissue, the nervous tissue, the cardiac tissue recovers from the chronic infection that they've had. And remember, just like an STD, if you find one tick-borne illness, think of others. So if the patient has babesiosis, make sure you also work them up for Lyme disease, ehrlichiosis, anaplasmosis, Borrelia miyamotoi, and it's the same for those illnesses. So don't forget, if you find one tick-borne illness, think about the possibility of others. Well, thank you very much for your attention. I hope this was helpful in your approach to a patient who presents to you with either a known or suspected tick bite. Thank you.